Good evening, everyone, and welcome to our webinar today. The Parkinson's Disease and Movement Disorder Society is an all-India charitable society working to improve the lives of people with Parkinson's and their families in India. We have free online Parkinson's sessions. Most of you all have joined our groups, but for those who are new, we have sessions where हम information और education देते हैं diet और nutrition के ऊपर, strength और flexibility exercise sessions होते हैं, balance और walking के sessions होते हैं, brain के लिए भी exercises होते हैं, जो अभी mental health बहुत important है तो उनके बारे में भी हम जानकारी देते हैं, tips देते हैं, speech and swallowing के लिए हम sessions रखते हैं और dance और creative और ऐसे fun therapies भी होते हैं. हम also special sessions रखते हैं care givers या care partners के लिए जो specially ये care partners के group के लिए है जहाँ पे वो उनके जो difficulties है वो exchange कर सकते हैं दूसरे caregivers के साथ. एक young onset Parkinson's group भी है जहाँ पे लोग जिनको diagnosis हुआ है between 21 to 50 years can join this group. और we also do different sessions like yoga, tai chi, dance और हम हमेशा कोई नए professionals लाते हैं webinar करने के लिए. You able to see the first slide?
Yes, now I can. Yeah, thank you.
Yeah. Okay, so sorry.
Yeah.
Okay, so we're the Parkinson Society, and as I said, we have free online Parkinson sessions. Right now, everything is online, where we do different things from balance and exercise to diet and nutrition, brain exercises, dance and creative therapies. We also have special sessions, as I mentioned, for caregivers, care partners, and also for young people with young onset Parkinson's. And we always encourage different types of therapies for Parkinson's, whether it's yoga, tai chi, dance. And this is just a view of our online sessions, how we do it. We do it on Zoom, Google Meet, sometimes WhatsApp as well. So now we're going to see a video of what we do at the PDMDS.
If you are a person with Parkinson, support is here.
Thank you, Shania, for sharing that. If you know anyone who has Parkinson's, please do ask them to contact us and we can help them. The contact details will be shared later as well. I would now like to invite Dr. Maria Barreto, the CEO of Parkinson's Disease and Movement Disorder Society, to introduce our speaker today.
Thank you, Nicole, and welcome everyone to this webinar. On behalf of Dr. B.S. Singhal and the Parkinson's Society, it's my pleasure and privilege to invite you, Dr. Pramod Pal, and to welcome you to this webinar. Dr. Pramod Pal is well known as Professor of Neurology at the National Institute of Mental Health and Neurosciences, Bangalore. With an illustrious education and training in movement disorders, including a clinical fellowship in movement disorders and human motor physiology, Dr. Pal brings much to this field. His professional interests include movement disorders, especially Parkinson's disease, dystonia, tremor, and spinocerebellar ataxia, rare movement disorders, functional neuroimaging in movement disorders. He has over 340 publications in national and international journals. He has held important positions and achievements, been the president of the Parkinson's Disease Society of Karnataka, editor-in-chief of the Annals of Movement Disorders, vice chair of the Education Committee of Movement Disorder Society, and a member of several organizations. We are extremely happy to have you with us here today, Professor Pal, and we are sure that every person with Parkinson's, every caregiver, and every allied health professional present at today's webinar is really going to benefit from what you are going to share with us. Welcome and looking forward to you. Thank you.
Thank you. Thank you, Maria, and I thank Professor Singhal and PDMDS to give me the opportunity to talk here. So I'll just first share my screen, and good evening all the viewers, and I'm sure that over the next 30 to 40 minutes, whatever I say, probably you will benefit to some extent with the information I'm providing. But I must say, and I'm afraid that there will be more of a scientific jargon, but I will try to be as simple as possible. And many things will be written in the text here, but you can ignore that. I'll just speak here. So I'm going to talk on today about the overview of medical and surgical management, the approach, management approaches in Parkinson's disease. And as you all know that this term Parkinsonism was used way back in 1817, 200 years back by James Parkinson, and probably he described the idiopathic Parkinson's disease, but after 2 centuries, this has transformed a lot. Many patients are not actually idiopathic Parkinson's disease, they have Parkinsonism. However, the birthday of James Parkinson is celebrated worldwide on 11th of April as World Parkinson's Day. And in 2005, this logo was designed to spread the awareness of Parkinson's. So what is Parkinson's disease? It is a neurodegenerative disorder. You can see here in the brain, a small area of the brain called substantia nigra. It secretes dopamine, which is reduced in Parkinson's disease. There is also probably an imbalance of other neurotransmitters in the brain as well. And to say in one sentence, the cause is unknown, though in about 10 to 15% of the patients, we can find some genetic cause, especially young onset Parkinson's disease. There has been postulations about early exposure to toxins, infections in the early life, but we still do not know. Probably there could be a genetic susceptibility because many of us are exposed to toxins, infections, but all of us do not get Parkinson's. And the crude prevalence in India is about 40 per 100,000 population in general, but age advances, the prevalence is higher. So still we do not know, probably it is a gene-environmental interaction which causes Parkinson's disease. So what are the cardinal motor manifestations? So I'll just, next few slides, I'll just briefly again touch about what is Parkinson's disease, what exactly we find in idiopathic Parkinson's disease. Most important is shaking of the hand at rest, that is called rest tremor, which is found in about 70% of the patients. Then slowness of movement, technically called bradykinesia, and stiffness of the hands and legs, and postural instability or difficulty in walking, tend to lose balance, but this comes in a very later stage. Initially, if it, the Parkinson's disease is always asymmetric, means one side of the body starts first and then the other side. And this asymmetry goes on for the rest of the life. So if your right hand is affected, you may complain of what is known as micrographia. You can see a normal person writes the alphabet M and O P, but a Parkinson's disease patient, if not treated, gradually the letter size decreases, what is known as a micrographia. Now, there are many others, so it is not only a motor problem. So there are many other so-called non-motor symptoms like decrease in the sense of smell, constipation, depression, anxiety, lot of sleep problems, drooling of the saliva. Then there start taken. I think there's internet problem. So there is, there are two types of symptoms, the motor and the non-motor symptoms in Parkinson's disease. And the most important symptom is, shaking of the hands, which is called rest tremor. Then there is slowness of movement, stiffness of the body. And then later part of the Parkinson's disease, you have instability or difficulty in maintaining balance. But these all come in the later part, the difficulty in walking and instability. And if the right hand is affected more in the initial stages, there is always an asymmetry, and this asymmetry goes on forever. In the rest of the life of Parkinson's disease. So if a normal person writes like M and OP in such a big size, in a patient with Parkinson's disease, the size gradually decreases, what is known as micrographia. So the not only motor symptoms, the patients with Parkinson's disease can have loss of smell, constipation, depression, anxiety, sleep problems, drooling. And in the young patients, especially some people who are being treated with dopamine agonists can develop what is known as impulse control disorder, which I'll talk later on. And some patients can develop hallucinations or visual hallucinations. But in general, to start with, Parkinson's disease never have psychiatric problems like psychosis or memory problem. And if somebody has that, then probably we are not dealing with a classical Parkinson's disease. Yeah, can you see?
Yes, not all Parkinson's patients are the same.
So not all Parkinson's, not all PD patients are the same. There are different type of, different patients can have different type of manifestations depending on some unknown factors, age of onset, genetics, stage of the disease, duration of the disease, progression of the symptoms, type of treatment the patient is receiving, and side effects of the medicines. And the degree of disability depends on which side is affected more. If the dominant, that is most of us write with the right hand, use the right hand as the dominant. So if it is more affected, the first affected, then the disability is obviously more. Then the occupation of the patient, stage of the disease, severity of the disease, progression, whether the patient has more of a shaking versus slowness. And then there are many other accompaniments like dystonia, freezing, etc., which can increase the disability. And then, of course, there are motor fluctuation in the later part of the disease and the non-motor symptoms, as I have already told you. Now, this is a timeline of a Parkinson's disease. So you can see here over 40 years, almost when the motor symptoms start here in this, this red dot. Before that, about 20 years before that also, you can have some non-motor symptoms like depression, sleep problems, anxiety, loss of smell. And when the motor symptom starts, it is also over years that the other problems, manifest, like gait and balance problem occurs much later. So it depends on the treatment strategy will depend on whether the patient is in the early stage of Parkinson's disease, middle stage of Parkinson's disease, or in the late stage of Parkinson's disease. Now, these are the two extreme ends of two different type of patients we can see. Here, there is the tremor is very predominant. You can see here very severe tremor. And this patient has very slow and bradykinetic and has difficulty in walking. So this patient also has Parkinson's. This also has Parkinson's, but they have different type of phenomenology. One has more severe tremor and other has more severe slowness of movements. Similarly, here, this patient, you can see here, this patient is a Parkinson's disease, but he has a bending of the back when he stands. So this is called a dystonia. And this again has a different type of management issues. Okay, so this is a dystonia with Parkinsonism. And this gentleman also has Parkinson's disease, but you can see there is a leg dystonia. He has a difficulty he has a bending of the leg. So again, these are more often seen in patients with young onset Parkinson's disease and also have a treatment strategies may be different. Now, as I told you, and I am going to elaborate again, that we have a lot of patients of young onset Parkinson's disease. See, these two gentlemen have young onset. One is the tremor predominant and another with bradykinesis and slowness predominant. And young onset is either age of onset less than 40 years or less than 45 years. So in India, these type of patients are quite common compared to the rest of the world. So we have different phases of Parkinson's disease in India, and probably it is also different to some extent from the Western countries, when they report the patients of Parkinson's disease. So our treatment has to be tailor-made. So we may see patients with symmetrical presentation, more tremor, sometimes with postural instability. So different patients have different manifestations of Parkinson's disease, and one should not compare their manifestations with other patients. So as I told you that young onset PD is, in our country, in an analysis of 2,000 patients, we found that less than age of onset less than 45 years in about 1/3 of the patients, and or age of onset less than 40 years in about 1/5 of the patient, and these are called young onset Parkinson's disease. And in our country also, the age of onset of Parkinson's disease is approximately 50 years compared to the Western population, which is approximately about 58 years. And the young onset has the disability is much more during the active period of life. And these patients have a lot of motor problems, motor fluctuation. They can have more of impulse control disorders. And it is definitely, more advisable that we treat these patients more energetically so that they can go back to the society and start and also continue working. And many of these patients have a genetic basis, and this is definitely a significant burden to the economy. Now, let us start with the treatment. What are the general guidelines of treating early Parkinson's disease? So we should confirm, or in fact, the doctor whom you are consulting should confirm that really it is a idiopathic Parkinson's disease, and with appropriate investigations. Most often we do some, MRI or some scanning is done. And even in young onset Parkinson's disease, we rule out certain diseases like Wilson's disease, etc. Then the doctor, before starting treatment, will look for postural hypotension. This means that you lie down, you see the blood pressure, you stand, then we see the blood pressure. If there's a significant fall in the blood pressure, sometimes, more than 30 millimeter systolic or 20 millimeter diastolic, this should be documented, because sometimes the medicine also can cause reduction of the blood pressure during standing. But in general, in a patient of Parkinson's disease, we never expect to have a postural hypotension without treatment. And if there is a postural hypotension, probably you are not dealing with a Parkinson's disease, probably you are dealing with another disease of similar nature called multiple system atrophy. So there are also, we should look for autonomic dysfunction like urinary problem, then sexual dysfunction, etc., and which usually does not happen in the early stage of Parkinson's disease. As I told you earlier, cognitive decline or memory problems, then abnormalities of eye movements, these also usually does not happen in patients of Parkinson's disease. So these should be always documented in the initial visit by the doctor. Then if it is a Parkinson's disease, then we should decide whether the patient really needs treatment at this time. And the patient as well as the caregiver, irrespective of the treatment we start or we do not start, should be explained about the nature of the illness and the type of therapies which are available. So this is in a nutshell. You can see here Parkinson's is motor symptoms which can be treated most often by medical management. Sometimes later on, as I'll discuss later on, surgical management is advised, and both will need rehabilitation and physiotherapy and counseling. The non-motor symptoms again needs medical management, and physiotherapy and counseling will be needed, counseling especially. And of course, there is a role of general lifestyle modification, rest and exercise, physiotherapy and speech therapy, and the need for the support groups. Now, what are the pre-treatment counseling for the patient and caregiver? So as I told you, we should explain that this is a disease which is progressive. There is no cure for this disease. And like blood pressure, like diabetes, this treatment has to be lifelong and it doesn't cure. It just controls the symptoms. Then you should have a realistic outcome of the treatment. See, the improvement will never be complete. It is very, very unlikely that improvement with one tablet later on will be complete. Though in the initial stages it may. The medicines are started in a very, very low dose, and it may take months to improve. Then the patient, even after good improvement, there could be good days, bad days for the patients, and always the symptoms, especially the shaking, worsen with anxiety and stress. Sometimes the gait problem starts, sometimes the freezing starts with anxiety. Then the medications will not have a same effect on all the symptoms. Sometimes the slowness may be more improved, or the stiffness may improve more, or the tremor may improve more. And usually the gait and postural stability does not improve to so much extent as the tremor or slowness improves. And then course of disease and response to treatment will vary between different patients. As I've already told you that there are different type of manifests in different patients, and the treatment has to be tailor-made for the patient. Then we should also explain, or the doctor should also explain all the probable side effects of each medication. So depending on the course of illness and the future need, there could be change of doses as the disease advances. There could be addition of new drugs or withdrawal of the current medications. And there could be need for functional neurosurgery. Often we call it what is known as the deep brain stimulation. Then also there is need to treat. So Parkinson's is not only a motor disease, as I told you, there is a need to treat constipation, sleep problems, urinary problem, depression, anxiety, sexual dysfunction, and impulse control disorders. And there is also non-pharmacological treatment. As I've already told you, yoga, meditation should be started from day one. It is not that you do first the treatment, medical treatment, and it fails, then do it later on. In fact, this physiotherapy, gait, yoga, meditation can be started in the early Parkinson's disease without giving any allopathy treatment. Now, is the treatment required at this stage? So you can see here, this is the patient who has, this is the patient who has very mild tremor of the left hand, and this is a very severe tremor of both the hands. So obviously this patient needs treatment. This patient, you can hold on the treatment if his age more than 65 years. You can just do not need to treat this patient immediately, energetically. So it depends on the type of symptoms, occupation, and benefits versus side effects of the medications. So I generally believe, and all the doctors also usually involve the patient and the caregivers in decision making, which medicine to use and what are the side effects, and how there should be a flexible and practical approach. The patient should be allowed to experiment with the doses. We insist on keeping a diary by the patient, the caregiver. You can note down what time, according to the medications, what time there's a worsening, what is the improvement, etc. Then the fluctuations of the symptoms, and there will be, and due to stress, intercurrent illness, and there is no need to panic. And one thing is important, that ensure that even if you have some other disease, you are going to the hospital, you should not stop the medicines for the Parkinson's abruptly or suddenly, because it can lead to a lot of different type of other problems. Okay. And we always believe that the doctor always learns from each patient. Okay. So it is not like, the cardiac disease or, diabetes, that we can always have a relaxation of the drugs. Sometimes you can take it late, sometimes early, but it should not be too erratic. Now, I'll just quickly go through some of the different medicines which we use. So the gold standard, you all know what will be known as levodopa. And this is the gold standard for treating patients with Parkinson's disease. And it is often combined with a enzyme inhibitor called carbidopa and sometimes benserazide. The common trade names for this levodopa, carbidopa is syndopa, tidomate, etc. And for levodopa and benserazide is madopar. Okay. And these are different, if you take the tablets, it gets absorbed in the intestine, it comes to the blood, goes to the brain, and then it is converted to dopamine. So it takes a long circuitous route to go there, to the brain. When there are certain medicines called dopamine agonists, which directly act on the receptors in the brain, and there are nowadays we use what is known as non-ergot derivatives, pramipexole and ropinirole. But there are certain drugs which can be given as a patch called rotigotine, and apomorphine nowadays is available either injection, pump, or subcutaneously, or even sublingual tablets. Then there are certain enzyme inhibitors. We already told you that we give carbidopa with levodopa as enzyme inhibitors to prevent the breakdown of levodopa. Then there are MAO-B inhibitors, rasagiline, selagiline, and recently safinamide, which are very mild nature of drugs, and it can help in the initial stages as add-on therapy. And then we have what is known as the entacapone, and sometimes in the new generation opicapone is available. But entacapone itself does not improve the Parkinson's disease. It is given along with levodopa to prolong the action of levodopa, but it should not be given in certain circumstances like who has dyskinesia. Then we also give a drug called amantadine, is an antiviral drug, which helps the patient. It has some neuroprotective effect, and it can be a mild anti-Parkinsonian drug. It is given along with other drugs most often. And then we have what is known as anticholinergic trihexyphenidyl. You may have heard the name called Pacitane or Parkin. But in general, though it is commonly believed that we should treat these patients, those who have severe tremor with trihexyphenidyl, it is not so. There is a lot of side effects, as I'll tell you later on, and we should not use the trihexyphenidyl. Okay, so I believe in starting slowly, so you can have in immediate release preparation called the levodopa carbidopa or controlled release preparation. If you start the starting dose of immediate release preparation about 50 to 100 milligram 3 times a day, and gradually increase weekly in increments to a total maximum dose if you're monotherapy 250 to 300 milligram per day. Now, this is the regime I follow, but in the initial stages, you can give either 3 or 4 times if you're only starting with levodopa and carbidopa. So start slow and go slow. So typically start at 8 a.m., 12 noon, 4 p.m., 8 p.m., and every 3 to 7 days increase by half a tablet. If you want to start, I'll tell you later on when to start levodopa, when to start dopamine agonist. If you start in pramipexole or ropinirole, we start in 0.125 milligram 3 times a day, or ropinirole 0.25 milligram 3 times a day, and gradually increase. A ropinirole with only monotherapy, you can have, the patient may need in a moderate state Parkinson's disease 3 milligram 3 times a day, and pramipexole will need about 0.5 to 1 milligram 3 times a day. There are different ways to convert one drug to the other. If you are taking levodopa or you're taking pramipexole, you are taking ropinirole, and you want to change to another drug, there is a way to change. Equivalent doses are there. Like 4 milligram of ropinirole is 1 milligram of pramipexole, etc. But that the doctor can do it for you. Then there are other drugs like amantadine. I am not going to go into details because we probably will take more of questions and answers. So this, as I told you, it can be given 100 milligram once, twice a day or thrice a day. And it can cause side effects. If you have hallucinations, confusion, all these things, you should not take this medicine. And very common side effect is ankle edema or levator reticularis. Then trihexyphenidyl, if you are going to start, it has to be given very slowly, 1 milligram increase by every 4th day. It is inexpensive, but it can cause a lot of side effects, as I'll tell you later on. Selagiline is, if you are giving it 5 milligram with breakfast or lunch, and it is given as a monotherapy. Rasagiline nowadays is given, it is about 0.5 milligram per day in the morning, and after 7 days, you can increase it to 1 milligram. These are given as a monotherapy in the initial stages, or it could be given as an add-on therapy with levodopa carbidopa. Then tolcapone we do not use anymore because of the hepatotoxicity. If you're using entacapone, when the patient is varying of symptoms, 200 milligram tablet can be given with each dose of levodopa carbidopa. Then, so what are the general guidelines? So usually we start one drug at a time. It is not that the first day you develop Parkinson's disease, you take all the medications from different categories. one drug is enough to control a Parkinson's disease in the initial stages. Absorption of drugs is better in empty stomach. Most patient is not able to tolerate dominant drugs on an empty stomach. So drugs should be taken after light snacks about half an hour before or 1.5 hours after a major meal. Redistribution of high protein containing food may be required in advanced Parkinson's disease for better absorption of the drugs. And during escalation of doses, if the patient experiences side effects, reduce the dose to the level without side effects, wait for a few days, and then again step up the dose. Domperidone tablet may be given half an hour before a medicine like levodopa, carbidopa to reduce the nausea in the initial stages. After that, the body adjusts and you need not worry, the side effects goes away. So these are some of the common side effects. You see the levodopa, all of these drugs can cause in the initial stages. And if you give 1 or 2 tablets twice a day in the initial stages, definitely you will get the side effects. Nausea, vomiting, loss of appetite. But pramipexole, propranolol can cause daytime sleepiness, then worsening of the impulse control disorder, especially hypersexuality. It can cause hallucinations, postural hypotension. Amantadine can cause ankle edema, as I already told you, and these are the things. But trihexyphenidyl, be careful. Parkin or Pacitan, it can cause dryness of mouth, constipation, blurring of vision. It should not be used in those who have glaucoma or prostatic hypertrophy or cognitive dysfunction. And apomorphine, sometimes it can cause cardiotoxicity and postural hypotension. So how do we choose a drug? So if there's a functional disability, if it is not there, you can just follow up and do physiotherapy. If there's functional disability, if age is less than 50 years, I usually start the initial drug option is dopamine agonist or a monoamine B inhibitor like selegiline or rasagiline or amantadine. But factors depends on a lot of factors we'll come to later on. If age is between 50 and 70, initial drug option is again a dopamine agonist. But if there are side effects like sleep disturbances, etc., you change over to levodopa. If age is above 70 and there is no problem with memory, there is cognitive dysfunction or psychosis is absent, you can still try cautiously dopamine agonist. If there are side effects, change over to levodopa. But if age is more than 70, there is a memory problem, psychiatric problem, there is no doubt that you have to only give levodopa, carbidopa. So presence of non-motor symptoms, if it is sleep disturbances are there, postural hypotension, which should not be there in initial stages, cognitive dysfunction, impulse control disorder, the best choice of medication is levodopa, carbidopa, or the traditionally available drugs like Sinemet, Syndopa, and Tidomate. Now let us come to the other. So this will be, you can treat the patients for the first 5 years like this. But after 5 years, about 50% of the patients who are having Parkinson's disease and who are on treatment will develop what is known as motor complications or levodopa-induced dyskinesias. And they are of the different types. So initial stages, what will happen that you take the medicine at 8 o'clock, at 12 o'clock, at 4 o'clock, you will not feel that the next medicine, even if you don't take the next dose, you may not feel anything. The body has enough capacity to tide over. But later on, what happens after a few years, what the phenomena starts, what is known as wearing off. So you take the medicine at 8 o'clock in the morning. Earlier, you used to not feel anything around 12 o'clock, but by now, around 10 o'clock, after 2 hours, you will feel that your body needs the medicine. This is called wearing off. Then there could be unpredictable off. Suddenly you become off. Suddenly you become, from the on state, there could be delayed on. So these are all motor fluctuations. And then could be, this is another disabling thing which can happen is during the on state, when you develop the improvement, when you get the improvement, you develop dyskinesias. So this is called on state dyskinesias, which is more often, I'll show you the videos, choric type, dystonic type, etc. Sometimes in the off state, when the medicine effect is going away, that time you can develop painful dystonia of the legs called off state dystonia. Sometimes you can have in both the states, and it's very difficult to manage. And then later on, sometimes you can have freezing of gait in both on and off state. So there are some of the typical videos. You can see this patient is having some dancing movements. This is a coriform movement, but in a very severe stage, in a young onset Parkinson's disease, it can be almost like a dancing ballistic movement. Sometimes, very rarely, you can get a migraine type of jerky movements in this body. This lady is having jerky movements. And sometimes you can have dystonic, means a cramp in the leg. You can see here when the patient is walking, you can see here this toe and foot is getting dystonic. So there are the various types of abnormal movements you can get after some years of treatment with dopaminergic drugs. So what are the general strategies for this motor complication? In general, try to titrate and fractionate the levodopa dose, take in an empty stomach, try small several doses rather than one big dose every 6 hours. Crush the tablets, mix with good deal of fluid or liquid or with some vitamin C, and try that absorption may be better. If a patient all along was taking only levodopa, you can add a dopamine agonist if there is no contraindication. If the patient was only on dopamine agonist, you can try and add a levodopa. Okay. So if there's simple wearing off, you consider again that the previous strategies which I told you, you add levodopa or you add dopamine agonist, add COMT inhibitor like entacapone. But if there's a delayed on, you can try again redistributing the protein or increase the dose of dopamine, etc. But if there are dyskinesias, peak dose dyskinesia, you stop the CR preparations, do not give COMT inhibitor like entacapone, and you decrease the individual dose of levodopa and increase the frequency of the individual dose, and consider adding amantadine and zonisamide. If the early morning dystonia is there, add CR preparation in the night, or early morning you can give an ordinary preparation. Sometimes the dyskinesias may be very, very severe and exhausting. You can see here, and this can lead to renal failure, rhabdomyolysis, fever, etc. And this type of patients definitely need admission in the hospital. Apomorphine is recently available in India, is in sublingual tablets also, but still it is not very good indications that the clear indications are there. And I'm not going to discuss much about this apomorphine. It can be given as rescue drugs for subcutaneously or as a pump in patients with severe off state and who is not suitable for going for DBS. And then freezing of gait. See, this is the patient which I already showed you, but you can see certain types of cueing can help. So if I give this cueing, so these type of strategies can be developed by the physiotherapist, and the patients can change their home environment by giving this type of cueings. So if there's a motor fluctuations, I don't have much of time, so I'm just going to just give you some ideas. Already I've told you, so the dyskinesias can be coriform, peak dose, or biphasic. Dystonia can be peak dose or off period, and freezing of gait. These are all the motor complications. So at a certain stage, after managing in the way I told you, you may not be able to manage fully, and then you may need to consider deep brain stimulation, which I'll tell you later on what are the indications. Now, what are the surgical procedures? So there are two types of surgical procedures. One is ablative, means you purposely make a lesion in the brain, like especially in thalamus or pallidum or subthalamotomy, or you do a deep brain stimulation. You give electrodes in certain areas of the brain. What is subthal? One is subthalamic nucleus, another is globus pallidus internus. Okay, so what are the good candidates? So those who have adequate response to medicines, but having the motor fluctuations, they are not able to tolerate a high dose of levodopa, carbidopa, or other drugs. So they have on-off fluctuations are there. The dyskinesias are impairing the quality of life. Their medication-resistant tremor, even if you have not tried for 5 years, usually we try the medicines for 5 years to see if, sometimes initially the patient can have Parkinson's disease, but later on we find that it could be turned out to be PSP or MSA. So we need to wait for about 3 to 5 years to see whether the patient behaves like a Parkinson's disease even after 3 to 5 years. But if a patient has a severe tremor, then is an exception. And there's a reasonable cognitive function is there. So these are the patients who can be considered, should be levodopa responsive. So any symptoms which responds to DBS is usually responds to levodopa carbidopa. Okay, so the motor fluctuations are there. There is no psychiatric problems, no dementia, and there's adequate trial of dopaminergic drugs has been given, and there's no major comorbidity. And usually we restrict it to 70 to 72 years. They should have a good support at home and be able to come for programming. And it is not a Parkinson plus disorder. Now, what symptoms may not improve after DBS? Any symptoms or sign which did not improve with levodopa except tremor. Then the speech problem, balance, freezing, cognition, these usually does not improve with DBS. What may worsen after DBS? The gait, speech, mood, behavior, or impulse control disorders. This may worsen after the DBS. So this is a patient, you can, 2-3 videos I'll show. This patient I had to cover the upper part to prevent, the identity. So you see, so severe tremor, and this patient could not afford DBS, but after doing a thalamotomy on the right side, on the left side of the brain, for the right hand, you can see his right hand is not shaking, but the left hand is still shaking. So these can be used. Thalamotomy, it is very cheap. It is about 20 to 30,000. You can do one side, lesioning of the brain, and which will reduce the tremor, especially. But sometimes we can do palliatomy also for dyskinesias. And they are the PD patients who underwent DBS. You can see here this patient with a very severe tremor before the DBS, and after the DBS, the tremor has significant improvement after the DBS. And this is a patient, the same patient which I showed you earlier. So the gait was so slow, and now you can see here after the DBS, the gait has significantly improved. Okay, in this patient. So they are the patients who underwent DBS. So the next 15 minutes, I will just talk on the management of the non-motor symptoms in early PD and in Parkinson's disease. So a large number of patients have PD, have non-motor symptoms in the beginning or before the onset of the motor symptoms. And these includes depression, fatigue, sleep problems, constipation, etc. So the constipation, just a guideline is that you should increase the dietary modification, increase the fluid and fiber and bulk in the food, increase the physical activity, stop anticholinergics if the patient was getting stool softeners, lactulose, and then later on you may need enema. If the patient is having swallowing problems, swallowing evaluation should be done. Soft diet, increase the on time, eat during the on time, and do not increase eat during the off time or while seeing TV or while lying on the bed. You should not do. Later on, other procedures may be needed. Many patients will have drooling of saliva because of the lack of spontaneous swallowing of the saliva. So these can be improved to some extent by swallowing exercises, and anticholinergic drugs can be given, but I do not recommend, or increase in the anti-PD medications. But we have long time back, we have actually given intrasalivary botulinum toxin injection and showed that this can definitely help to reduce the saliva. And it is now a standard of therapy for patients with Parkinson's with severe drooling. We can give botulinum toxin in the parotid glands. If there's the orthostatic hypotension, which you should not have in the early stages of Parkinson's disease, you can reduce or modify antihypertension if possible. Behavior modification, increase the salt and fluid intake if there is no cardiac problem. Elevate the head on the end of the bed. Cross your legs when you are standing or sitting. Do the leg exercises. And later on, you may need to add fluorocortisone or midodrine. If there's a, so these are the problems of, so I'm not able to see the screen here only. So just one second. Yeah. So there could be a lot of sleep problems, and you can have medication-induced sleep problems, nocturnal PD symptoms causing sleep problems, idiopathic sleep problems, and depression itself and dementia itself can cause sleep problems. So all these things has to be evaluated. And many of the patients with Parkinson's disease, even before the motor symptoms, they can have what is known as REM behavioral disorder of sleep. They suddenly, after about 2 hours of sleeping, wake up and start shouting, screaming, banging, hitting the person who is by the side of him or her. This is known as REM behavioral disorder of sleep. This can be treated very adequately with giving clonazepam, and you should tell the doctor. Okay. So I think. Not able to see. So there could be other thing is excessive daytime sleepiness. So the medication induced, like as I told you, the pramipexole and droperidol can cause excessive daytime sleepiness. So again, these should be evaluated. These patients should be evaluated for drug-induced excessive daytime sleepiness, or it could be idiopathic. And then in that case, you have to correct the nighttime insomnia, and then depression, dementia itself can cause excessive daytime sleepiness. The patients can have other sleep problems, like as I told you about the REM behavior disorder of sleep. The patients can have myoclonus or jerky movements of the legs. They can have periodic leg movements in the sleep or restless leg syndrome. So, and also they can have leg cramps. So these should be, so fine, I'll just cover the lower part. So, there can be other problems which the patients can have is nocturnal urogenital dysfunction. So what happens is that this is really disturbing to me. So urinary symptoms can be seen in about 2/3 of the patients of Parkinson's disease, and they increase with disease severity, and especially the lower urinary tract symptoms, urinary urgency, urinary frequency, nocturia or retention. And this is associated with increased risk of fall and lower mental scores. And sexual dysfunction is also seen in about 20% of the patients. In men, you can have erectile dysfunction and premature ejaculation, and women, you can have vaginal tightness, loss of lubrication, etc. And in both the genders, there is a decreased libido. So, but hypersexuality is also seen in about 4% of the patients, and especially young patients who are on dopamine agonists. And these should be carefully asked by the doctors, and also the patients should take the liberty, if they're having sexual problems, especially hypersexuality, to tell the doctors. So what is the approach to management of urinary symptoms in Parkinson's disease? You should have proper identification of the problem, whether it is PD or age related, like benign prostatic hypertrophy, or local cause or infection, may require investigations including urodynamic evaluation. The management strategies include treatment of benign prostatic hypertrophy if it is present. In the female, it could be specifically like weight loss to help reduce the pressure on the pelvic floor, topical estrogens, surgical treatment like slings and suspensions, and Kegel exercises. And then behavioral modifications will be needed, like timed voiding, decrease the caffeine and alcohol, and overall fluid intake before sleeping should be reduced, and voiding before the bedtime. Yeah. So there are other strategies to treat urinary urgency. Like there are different medications which your doctor will advise, antimuscarinic agents, or there could be other drugs like mirabegron, then desmopressin, intradermal injection of botulinum toxin. There are also patients can have chronic urinary retention, and in that you have to rule out medication-induced urinary retention, especially anticholinergic drugs. And there's another important group of disorders can cause what is functional incontinence. There is immobility and fall risk and dementia. For these patients, there should be unobstructed, adequately lit path to the toilet. There should be bedside commodes, adult diapers, external condoms, etc. And preferably, we try to avoid and defer indwelling catheters. So, what is the approach to management of sexual dysfunction? So, there should be proper history, clinical examination, appropriate investigation, rule out other causes like age-related factors, systemic illness, vascular disease, autonomic dysfunction, depression, local causes, and severe motor symptoms. And you can maximize, to treat the sexual dysfunction, you can maximize the improvement of motor symptoms in Parkinson's disease, treat depression and counseling as required. You can, under supervision of doctors, to use phosphodiesterase inhibitors like sildenafil. In women, artificial lubricants, precoital voiding, etc., can be taken care of. Decreased libido in men, you can, in the Western countries at least, they have used daily transdermal testosterone gel, and in women, a centrally acting serotonin antagonist or agonist can be used. If there's ICD or hypersexuality, you should reduce or stop Dipexor. Now, another important symptom in patients of Parkinson's disease is depression, which can start many years before the onset of Parkinson's disease, and it can be present in more than 50%, and in some studies it's shown that it can be more than 90% of the patients can have depression in some part of their life after they have Parkinson's disease. And this reluctancy to admit by patients as well as the caregivers. Depression may not be easily distinguished from the symptoms of PD. There is a loss of initiative, cooperation on the patient's part, and can interfere with delivering effective care. So if there's depression, you should see whether it is sustained depression or just a periodic just a transient of depression. And if there's sustained depression, you will need drug therapy or counseling, and sometimes in very severe cases you may need ECT. In drug therapy, most often we use escitalopram and sometimes venlafaxine. Then another non-motor symptoms which we find is anxiety, and it may spill over to the caregivers. And this anxiety is present in almost 50% of the patients. Risk factors include young age at onset, rapid progression and severe motor dysfunction and motor fluctuations. Severe anxiety can be associated with off state. Okay. And this anxiety should be treated, and very good medications are available to treat anxiety. So, as I told you that if there are off-state related anxiety or anxiety attacks, then apomorphine or short-acting benzodiazepines can be given. And the sustained anxiety, again, you need to evaluate and correct the underlying factors, relaxation therapy, antidepressants, and reduce amantadine, selegiline, and triacylphenidine. There are other non-motor symptoms like pain and fatigue, etc. But in all these cases, apart from ruling out secondary causes like vitamin D deficiency, musculoskeletal problems, you should always rule out depression. Psychosis in PD is one of the very important topics, and it can occur in about 50% of the patients throughout the lifetime. It is a common reason for inpatient admission and nursing home placement. More common in patients with cognitive dysfunction and dementia, frequently associated with and triggered by dopaminergic therapy and anticholinergic drugs. In my practice, I have seen many patients who have started on Pacitin or Parkin or Selegiline. They come with hallucinations. So other factors can be infections, metabolic or neurological disorders. So most often what the patient tells is that they can see someone's face or animal's face. And in the very early stages, you can have a sense of presence, means as if he feels that somebody is standing behind the back or somebody is going in front of him. So these are the things which it should be detected very early and told to the doctor so that appropriate medications can be started or changed. And hallucinations, other modalities also can occur, like some crawling sensation of the skin or hearing something. And there could be also some false belief, a belief like which is not actually, there is a belief contrary to the evidence, like you believe or start believing that your spouse is not faithful. So these are very the common things which comes, which is known as delusion of infidelity or paranoid delusion. Somebody is going to harm you, poison you, or somebody is controlling your mind. So these are all abnormal thoughts. And this can happen sometimes because of the medicines in patients of Parkinson's disease. So you should always tell the doctor that you are having these problems. And sometimes the patient can have acute psychiatric problems, and they can come with catatonia or delirium. And so these patients should be admitted. So what is the policy of this? So if the management of acute psychosis in patients of Parkinson's disease, look for any recent modification in treatment regime, discontinue the last medicine, taper and stop anticholinergics, MAO-B inhibitors, amantadine, and only continue on levodopa, the lowest dose possible. Look for reversible causes like infections, drugs, metabolic derangements, etc. And then your doctor may like to start a treatment apart from the medicines given for the psychosis using quetiapine, clozapine, or olanzapine. Impulse control disorders, I don't have time. I think I have to finish in another 5 minutes. So this is common in young patients, and they can include hypersexuality, binge eating, pathological gambling. It can be present in up to 40% of the patients with young onset Parkinson's disease. And sometimes the patients do not need so much of dopamine or dopaminergic drugs, but they go on taking it. This happens especially after long PD, and the patients I don't know what is happening now. And they develop what is known as the dopamine dysregulation syndrome. And these patients need to be treated. What is something's happened here? So these patients need to be treated. You should tell the doctors there are some risk factors for ICDs like main gender, family history of alcohol, smoking, gambling, addiction, those who are unmarried, those who had a novelty-seeking behavior. And most often these are treated when you stop the pramipexole or other dopamine agonists. So I'll just stop this. So there are other non-motor symptoms like cognitive dysfunction and memory problem. By and large, this does not happen in a classical Parkinson's disease, but you should rule out other causes of memory problems like anticholinergic drugs, chronic subdural hematoma, hypothyroidism, vitamin B12 deficiency, low sodium, or depression. So these are the things which need to be on the lookout, and you have to rule out these causes before telling that the patient is having any real cognitive dysfunction. So there are different emergencies in Parkinson's disease. I should not go into this, but just want to tell you one thing, that the patients, if you stop abruptly medications, patients can land up with very high fever and what is known as neuroleptic malignant syndrome. The patients become very stiff and develop fever and very severe Parkinson's disease. This is admission needs to be done in hospital and managed in a different way. And there could be DBS related complications. The surgical procedure itself can cause problems. Otherwise, there could be stimulation related problem, hardware related problem. There could be accidental off or on, and the patients can come with severe dyskinesias or chorea or ballism because of the stimulations. Or sometimes we have seen in COVID time, suddenly the DBS stops because of the battery failure and the patient comes with severe stiffness. So there are last 3 slides. I just want to give a message for the all of you that all the PDs, all Parkinson's are not same, and you and maybe having a unique problem. Don't compare the symptoms, progression, or response to treatment with other PD patients. Confide in your treating doctor, and don't seek multiple consultations. You go back to your doctor who has started treatment. There will be ups and downs depending on stress and many factors. A follow-up with your doctor every 6 months may be enough. Beware of the non-motor symptoms, which I've already told you. Inform your doctor promptly if you have hallucinations, impulse control disorders, or dizziness on standing. And you may have other illness which needs equal attention. About treatment, PD is not a curable disease, which I already told you. It is like just treating fever with paracetamol, and it does not treat the underlying cause and give time for improvement. Most patients in early and moderate stage disease needs only 1 or 2 categories of anti-PD drugs. Be aware of the side effects of medications and don't stop the medication suddenly, as I already told you, and maintain a diary. Maintain sometimes a video clipping by your caregiver may be very important, and you can show to the doctor in your next visit. And those who have undergone or want to undergo DBS, you should realize that DBS does not cure PD, usually improves only those symptoms which are improved by dopaminergic medications. Decrease the off time, increase the on time with reduction in the dyskinesias, and speech and gait and balance may not improve. There is a need to continue medications after DBS. You cannot stop most often you cannot stop the medicine, though the medicine requirement will come down by about 50%. But as age is advancing, as disease is progressing, the medicines later on may have to be increased. Stimulation-related side effects can occur. Even psychiatric problem can occur, which was not there earlier. And before considering DBS, you should always realize that if you're not taking a rechargeable battery, the battery lasts for about 3 to 4 years. You should have adequate resources for battery replacement. You should have doctors easily available for programming the DBS, and efficacy of DBS is often different in different patients. However, indications for DBS should not be that only the medications is not working or it is a last resort. There are well-defined criteria for DBS, and you should be aware of that, and your doctor definitely will tell you. So I'll stop here. Thank you for your attention. I am sorry for the problems which I had with the slides, and I'll be happy to take questions from you all.
Thank you so much, Dr. Pal, for that very, very informative session. I'm sure people are going to go back. ये session जो है YouTube पे भी हमारे Parkinson's NGO के YouTube चैनल पे होगा, तो अगर आपको वापस रेफर करना है तो आप रेफर कर सकते हैं. But we had a lot of questions come in, but I'm going to start off with they want to know that do all doctors recommend only Syndopa as the first drug when you're diagnosed with Parkinson's, or can there be different drugs which the doctors can give, and why do they give different drugs?
Yeah, so this is a question which everyone asks, and I've already showed a slide that if Syndopa is actually one trade name. It is a levodopa carbidopa preparation, and yes, it is a gold standard when there's a diagnosis is in doubt whether you need to test whether really the medicine is helping or not. Syndopa or the levodopa carbidopa may be the drug of choice. But usually in younger age group and those patients who are not having any psychiatric problems or low blood pressure, we try out first with dopamine agonists called pramipexole or ropinirole. So these are the 2 drugs which we commonly use rather than levodopa carbidopa. But if a person cannot afford, levodopa carbidopa will be the best choice because it is cheaper than the other medications.
Thank you very much. Just to follow up to that question, there are some young onset people with Parkinson's here who have said that they have been prescribed safinamide. So whether that's also an option only for young onset?
So safinamide is recently started here. We did a trial long time back. It is just like, it is a, only with safinamide may not be able to treat your Parkinson's disease. In the very early stages of Parkinson's disease, if you really want to take a treatment, a monotherapy can be started like giving amantadine or rasagiline, selagiline. Safinamide we usually give along with other drugs, and it has some neuroprotective effect, and by itself it will not be an effective drug in treating a moderate state Parkinson's disease. Okay, so it is an add-on therapy. It can help to prevent dyskinesias in the long run, so it can be given. So I would recommend that you give this not in the initial stages of Parkinson's disease, maybe in the after 2-3 years down the line, when you are taking other medications, you can just give an add-on safinamide. But there should be some precautions. Sometimes safinamide can cause side effects.
Okay, thank you very much. There's a patient who has asked कि उनको बहुत off periods होता है, तो वो क्या कर सकते हैं off periods के लिए? दिन में बहुत बार, it comes very often during the day, the off periods.
See, it depends on how many years you are having Parkinson's disease and what medications you are taking. And so by and large, the medicines what you are taking, either the strength of the medicine has to be increased or you have to take the medicine more frequently. So this is the way to manage an off period. Or if you are taking only Syndopa, then we can add another medicine like propranolol, pramipexole, amantadine, or safinamide, and increase the strength of the dopaminergic drugs in your body. Or other things is that we can add entacapone. If you are not having severe dyskinesias, only off periods, along with levodopa, carbidopa, we can add entacapone tablet. We can add it about 4 to 6 times or even up to 8 times a day. So it depends on what medicines you are taking now, how often you are taking, and what is the stage of your Parkinson's disease. Later on, if you may be a candidate, if the other other indications are okay, for a deep brain stimulation or for apomorphine to treat off periods.
Thank you very much. Also, Doctor, what is your opinion on alternative forms of treatment? So we had lots of people ask us about naturopathy and homeopathy and Ayurveda, and whether they can use that instead of allopathic medications. So
Ayurveda treatment, see, all our levodopa active preparations comes only from the Ayurveda muciniferins, and it is an active ingredient found in Ayurvedic medicines. But the allopathy medicines give a concentrated form of that. Okay. Now, about all the other medications which you are telling about, Chinese medications or homeopathy, I do not have much experience on that. I don't have any experience on that. So as long as it is not harming you, you can take it. But it is up to you, because I don't think any doctors who are practicing allopathy can give any advice about the homeopathy or the other traditional medications. But you are welcome to do any other form of treatment, which is like physiotherapy or massage. But massage, and many people ask whether you can go for massage. Yes, you can do, but it is like any other physiotherapy, but it should not be done to such an extent that it can damage your bone or joint, etc. So probably yoga, meditation, physiotherapy, tai chi, etc. Can be helpful as an add-on treatment for patients of Parkinson's disease.
Thank you. There's another question about, can someone adjust the Syndopa doses on their own if they feel that their off period has come earlier, or if they feel their symptoms are difficult to manage? Can they adjust it, and should they adjust it on their own?
Yeah, you can. So I already told you that you should have, the patient or the patient's caregiver should have the liberty to adjust these drugs depending on you. So you should keep a diary, and suppose you are feeling that you are today very stiff and you need a half a tablet more, you can take it. Okay. You will, after some time, you will realize that if you take little more tablets, you will feel much better if you are responsive to the levodopa, carbidopa. If you take too much, you will develop severe dyskinesia. Okay, so you can adjust these doses little forward, bring it forward, or bring it postpone the dose, or bring it forward, or increase the strength of the dose. And these medicines are not like treatment of blood pressure or treatment of diabetes, where you need exactly the same dose every day, or depending on your blood pressure and depending on your the blood sugar level. You can adjust to some extent, but don't be very erratic, because our body always likes a smooth level of the medications. So if you are taking, see, you should not take today 3 tablets and tomorrow 5 tablets. It is not like that. Half a tablet here and there, you can adjust. Half an hour here and there, you can adjust depending on your occupation, depending on important personal commitments, but not to a very erratic schedule. There should be always a smooth level of, see, you should remember that whatever you're taking, it is getting absorbed in your stomach, it is going to the blood needs a smooth level of dopamine, or the brain needs a smooth level of dopamine. So that smoothness, the level should be equal both in the night, in the day. If there is too much of fluctuations in the level, later on the motor complications are much more. Okay.
So coming to that about the motor complications, I think a lot of people, especially those who are recently diagnosed and those who are younger, are scared of the side effects of some of the medications, and so they don't want to start the medication. So what is your advice to those who are scared to start the medication because they think they may develop side effects later on?
Okay, see, I was telling you that it is good that you are aware of the side effects of the medicine. So it is a motor disability, and if you are retired, you do not want to exert too much, you can postpone the medications. Okay, but it is not correct to say that these medications ultimately cause the, even if you do not take the medications, probably you will develop side effects. There was a time when levodopa or the syndopa was being accused of causing degeneration in the nervous system and causing this drug-induced side effects. But now we know that even the dopamine agonist, if you start the dopamine agonist, lubinolone, pramipexole, it will cause side effects after about 5 years. So those patients who are taking treatment after about 5 years, you will develop side effects. So there is not much to choose. What I advise is that if your disability is so much that your social life as well as the occupation is getting compromised, you should take medicine. Forget about the side effects. Side effects we can treat later on. It is in a dark or gray area that whether really the products of this medicine cause side effects, and if you're not taking the medicine, you won't have side effects. You can enjoy your first 5 or 10 years of life with a good motor ability, no tremor, no slowness, stiffness, rather than thinking that I should reduce the dose so that I do not get the side effects. It may be side effects. Yes, theoretically, it may be that 1 year earlier you may get a side effect than 1 year later. But it is better to enjoy about 7 or 8 years of initial Parkinson's disease with good amount of medications.
Thank you, doctor. That was a very important question. The next question is, what is the difference between Syndopa Plus and Syndopa CR?
See, people usually ask about Syndopa Plus and Syndopa 100. Say Syndopa Plus is 125 milligram of carbidopa is there. Those who have a problem so carbidopa is the active, not the active ingredient, it is the enzyme. So in Syndopa Plus, there is 125 milligram carbidopa, 100 milligram of levodopa. Syndopa 110 is 125, it is 110 milligram of carbidopa, 100 milligram of levodopa. So people who have a gastrointestinal, uptake is not proper, or the enzyme is not properly inhibited, they prefer to take, or we prefer to give 125 or Syndopa Plus. So we give a little extra dose of carbidopa to prevent the breakdown of the levodopa in the stomach. Okay. So I always prefer the Syndopa Plus. But what you are asking is a different thing. You are asking about the CR preparation. Now, CR is nothing but a controlled release preparation compared to Syndopa Plus or Syndopa 110, which is an immediate release preparation. Now, most often we need an immediate release preparation because one is that you need to have within half an hour you get an effect, but the effect goes away early. And in general, in India, we do not find that the CR preparations are very good compared to the Western hemispheres. We have found that the Cinemax CR may have a better bioavailability, or better. I find it better than the whatever preparations are available in India, the CR preparations. But yes, if you want to take a CR preparation at the bedtime, the effect can last for about 8 hours or 12 hours. So you can take the CR preparations. So if you take Syndopa Plus, you need to take 3 to 4 times, sometimes 6 times a day. If you take Syndopa CR, 250 milligram, you can take only 2 or 3 times a day. But CR preparation should not be given to those patients who are having peak dose dyskinesia. Okay, so peak dose dyskinesia, if you start having peak dose dyskinesia, it is better to stop the CR preparations.
Okay, thank you so much. Doctor, you had mentioned about the non-motor symptoms in Parkinson's, and someone has asked about acting out in the night, if there's any medication that can be given for that.
Yeah, so I briefly told you about what is known as REM behavior disorder of sleep. So I'll just simplify it. When we sleep, there are one is called non-rapid eye movement sleep, and another is rapid eye movement sleep. Okay, so after about 1.5 hours, we go into REM sleep. In that time, we start dreaming. Okay, so that time, in a normal person, the muscles are all relaxed, and we do not have much of movement of the hands, muscle of the body, etc. In patients who have this REM behavior disorder of sleep, or RBD, they do not have that normal low muscle tone during sleeping, and they start dreaming. They have vivid dreams, and they start acting out in the dream. And they sometimes chase animals, sometimes chase thieves, sometimes bang the caregiver or the spouse. So this is called REM behavior disorder of sleep. It is very well known that patients of Parkinson's disease have this in a much higher frequency and prevalence compared to those who do not have it. Even if it can start about 50 years before the onset of motor symptoms of Parkinson's disease. But there is a very good treatment for this. So this treatment is giving a tablet called clonazepam. Because you should consult your doctor. Clonazepam, it is a benzodiazepine, or it is a sleep-provoking, hypnotic or anxiolytic. But it can be given in the night, and usually it takes care of the RBD or acting out behavior in the sleep. But there is a caution. It can cause drowsiness. It can cause, if you are trying to drive next day, it can cause drowsiness, and driving may not be safe. And another thing is that many other abnormal movements or acting out in the sleep can occur apart from the REM behavior disorder of sleep. Okay, there can be in certain population, there could be walking somnambulism, there can be seizures, nocturnal terrors, all these things. But your doctor will rule out all these things. And in general, in Parkinson's, what happens is that we give all these medications. These are all dopaminergic drugs. These increase the dream activity so there is a vivid dreams is found in patients who are taking all these medications. So acting out could be a part of this as well as the RBD. And there's a treatment for that, and definitely we can treat you.
Okay, thank you. I think there are 5-6 questions truncal change in posture. It could be truncal dystonia ke bare mein, ya both and twisting is what they have said. So is there any management for?
So, okay. So see, what happens is that in classical Parkinson's disease, over years, if you do not treat, you tend to stoop forward, okay, bend forward. That is stooping posture. And when you take the medicine in the initial stages, yes, you become straight. Because the muscle tone increases, the flexion tone increases, and you stoop forward. So this is one aspect of truncal changes in Parkinson's disease. Some patients, but usually what is seen in multiple system atrophy, they tend to have a tilt towards one side. Okay, that is called leaning tower of Pisa. That type of, it tilts to one side, and they do not respond much to the medications. But if this occurs in the early stage of Parkinson's disease, probably we are not dealing with the Parkinson's disease. It is a Parkinson plus disorder, and different investigations are there to find out how it can be treated, or this is not a Parkinson's disease. Some patients of Parkinson's disease can have what is known as a camptocormia. They go on bending forward after walking for some time, and then gradually stoop forward. Okay, this is very, very difficult to treat. We initially start with adjusting medications, And these patients can have dystonia of the trunk also. So as I showed you in one of the videos, that many patients of Parkinson's disease can have dystonia also of the truncal muscles. So if there is a dystonia of the truncal muscles and Parkinson's disease, they may respond, both may respond to levodopa or dopaminergic drugs, but sometimes the dystonia may not respond. So dystonia may, in addition, respond to anticholinergic drugs like Parkin, Pacitin. They may respond to baclofen. They may respond to antispastic drugs. And in other situations, sometimes we have done deep brain stimulation early in the disease in a patient with Parkinson's disease with dystonia. But here the stimulation site is not subthalamic nucleus. Here, most often we go for GPI, that is globus pallidus internus, in patients who have Parkinson's disease and dystonia. But again, it is not very common, and your doctors first should examine you in the off state, on state, and then decide how to treat dystonia.
Now,
and of course, the physiotherapy is very important. Physiotherapy is always very important, especially for truncal postures and dystonia, and sometimes not in PD, but different type of dystonia, truncal dystonia, braces may help. Touching, in different type of physiotherapeutic or brace and all these things can help to some extent.
Sensory checks can help.
Yeah.
Thank you. Now, just moving on to deep brain stimulation, we had a lot of questions.
Yeah.
Patients पूछ रहे हैं कि what is the minimum age that someone can do DBS, or is it recommended कि वो जल्दी उनको DBS करना है या थोड़ा time prolong करना है?
Okay, so good question. So DBS minimum age means, देखो, Parkinson's disease is age starts, usually we see the Parkinson's disease around 40 years, 45 years, most commonly around 50 years. Okay. DBS is also used in many other diseases, and we have done DBS in children as low age as 6 years also for dystonia. Sometimes very young children can also develop Parkinsonism dystonia. We have done DBS in them also. So there is nothing like minimal age for deep brain stimulation in the context of Parkinson's disease. There is a maximal age. Maximal age we do not want to do after 70. Just recently we did a patient of 72 years. But after 70, always we should be cautious because there can be cardiac problems and all, comorbidity, etc. But there is certain points we should remember is that apart from the very severe tremor, which is not responding to dopaminergic drugs, DBS usually is postponed for at least for 3 to. There is a concept nowadays of early DBS, early STIM studies that there, early DBS. They propose that probably it helps to prevent the downstream changes in the brain, the plasticity changes. So after 3 to 4 years, when the motor fluctuation starts, wearing off, dyskinesias, probably that time you can think of doing DBS. Okay, but your doctor should evaluate you, and there is always a procedure to follow. I usually admit the patient overnight, for 2 to 3 days, stop all the medications for about 1 day, sometimes 2 days, see purely in the off state how much is the disability, then give medications and see in the on state, maybe over 1 or 2 days, how much is the improvement, and then counsel the patients what will improve, what will not improve with DBS.
Okay, thank you so much. People are also asking, you did tell them what won't improve with DBS, but what are the side effects of the DBS procedure?
So I told you that what does not improve is DBS as a rule of the thumb is that whatever is not improving with a good challenge or good therapy of levodopa, carbidopa, or cinnamate or syndopa usually does not improve with DBS. But in general, sometimes, most of the time, the voice, the balance problem, the gait problem, sometimes there's a freezing of the gait in the on state, or if you are having sudden on, sudden off, when you are totally on, you are having sudden off. Okay, these are the things which probably DBS will not help you. If you are having non-motor problems like psychiatric problems, DBS may worsen. So usually we do not do DBS in patients who have a frank psychosis. Okay, your memory will not improve with DBS unless memory was a problem because of some other cause, etc. Sleep problems may not improve with DBS. Now, the next part of the question was what DBS itself can cause problems.
Right. Post doing DBS, are there any risks or side effects?
So once we evaluate the patient for DBS, we rule out any comorbidities like cardiac problems, because the DBS operation takes about, at least, in the expert hands, it takes at least 4 hours to 6 hours. Sometimes earlier we used to do for 6 hours, 8 hours, 10 hours. Some people do only one side first and then do the second side after 1 or 2 months. So when we prepare you for a patient for a DBS, you are not made unconscious during the time of DBS. Okay. Only in the last part, about 15-20 minutes, when we need to put a pacemaker, that time a brief anesthesia is given. Otherwise, during the time of DBS, you are fully awake, and we try to see you by stimulating different areas of the brain, how effective is the stimulation during and you are off state fully. Okay. You are not on medications. Now, the side effects of the DBS. Now, yes, there are side effects, but it is very rare. And during the time of operation, like any other operation, it is a blind procedure. When you are putting the electrode, that is a stillet, inside the brain, on this side first and then the other side first, it can sometimes hit a blood vessel. Sometimes the brain can get damaged. If it hits a blood vessel, very rarely it can cause a infarction or dead tissue. Immediately after the post-operative period, that dead tissue can cause fits, that is known as CVT, cortical venous thrombosis. Very rarely there could be a very mild weakness on one side, like a stroke phenomena. So these are the operation-related complications in the next 24 hours. Immediately after the operation, for the next 7 days, there could be a lot of improvement as well as complications. Improvement occur in the form that what is known as, even immediately after the DBS, we do not start the machine. We wait for about 7 to 10 days. But the patient definitely gets sometimes very good improvement for short-lived, for about 7 to 10 days. This is known as the additional effect, and that is a good sign. But some patients, after the DBS, after 24 hours, they become very violent. Sometimes they become irritable. The motor symptoms increase. And during the time of DBS, if you are elderly and the age is advanced age, there can be air which goes inside the hole. Though the surgeons may try not to allow the air to go inside the hole, they seal it. But since the brain is already shrunken because of the age, the air goes inside the brain, and sometimes that can cause headache and altered, delirious condition immediately post-operative. But these usually gets absorbed. That is known as the pneumocephalus. Then after a few days, then we start doing the programming. During the time of programming, there could be still stimulation-related changes, side effects. Sometimes you can have too much stimulation on one side of the face. The opposite side of the face can get twitching, or the opposite eye can have twitching. You can have abnormal sensations on the opposite side where it is being stimulated. So these are the stimulation-related side effects. But usually after 2-3 programmings, it settles and the doctor can take care of that. Then there are certain side effects which can be related to the leads which we have put. So leads can get broken. Sometimes it can migrate. Sometimes there could be wound infections in where the site of battery or the site of operation. So these are very rare in good hospitals, in good setting. Usually it's not so much of a concern.
Thank you very much. There's also questions about the cost of deep brain stimulation. What does it cost in India, and why is there such a difference in the price in different places?
Okay, so the cost in India is probably much cheaper than anywhere in the world. Okay, if you are in a government setting, government hospital, I'll tell you about Niemann's first, because this is a government hospital, it's a central institute. We only charge the patient for the operation. Okay, and that is also at a very subsidized rate. And if you take a non-rechargeable battery, that is the ordinary Medtronic battery, which is commonly available, the battery itself, which is put here, and the leads cost about 4.8 to 5 lakhs. And some of the hospitals also get some concessions from the government. So by and large, a DBS operation, if you're taking a non-rechargeable battery in our hospital, will not cost more than 5.5 lakhs. Operation charges are very less. Even if your patient is BPL card holder, poor patient, even the operation charges go down further. Okay, and we may be able to do within 5 lakhs. If you are taking a rechargeable battery, then the cost depends on the type of battery. Medtronic sells it for about 10 lakhs, the operation cost, including the operation cost for in our hospital. Other something, I think Boston Scientific is about 14 lakhs, and that goes on for a longer time, the battery duration. The same operations in the private hospital may be costly because of the cost of the operations and the stay and all, etc. In our hospital, see, after the operation is done, you need a lot of programming. And each time, first time you come after 15 days, then after 1 month, then after 3 months, after 6 months, after 1 year, and then every year. So programming in our hospital, we do not charge the patient, but in certain hospitals, yes, there will be charges for programming. Sometimes you need to admit the patients for programming in the initial stages, make the patient off and do programming. That has a charge, as a hidden charge is there in some of the private hospitals.
Thank you. Just the last few questions. Are there any newer treatments, like things like nasal sprays or anything which will be easier for people to administer or to take their drug? Can you?
So I have not gone into the newer treatments. Yeah, definitely nasal spray has been marketed, and it is like Astellin inhaler or those who have asthma, that type of spray. We do not have hands-on experience here in India. It is yet to come. So this is one, and there are some types of preparations available of levodopa carbidopa itself in different granules are there. Some will get immediately released, some will get later released. So it's a combination of a immediate and late release type of granules may be available. The patch is there, rotigotine patch. Then you can have sublingual apomorphine is available now in India. That we have just marketed about a month back. That can be used, but still we are not yet started properly. And then subcutaneous apomorphine is already there, plus apomorphine pump is there. But there are different indications for that. If anyone wants to know, I can tell. But in general, it is still costly and not afforded by majority, because apomorphine itself has a lot of side effects, and vomiting is one of the factors, and cardiotoxicity is there. So if a patient can afford DBS, we will always prefer DBS than apomorphine.
Thank you. Doctor, also, there are some questions about stem cell therapy and Parkinson's.
Yeah. See, in a nutshell, stem cell therapy is not, as of now, recommended for Parkinson's disease. Neither for any of the Parkinsonian plus disorders also, stem cell therapy is not recommended. And there were earlier studies on grafts in the brain and all, that also is a failure. So stem cell therapy is not recommended. We have seen many patients who have undergone stem cell therapy in the blood or in the spinal fluid, and later have come back after 1 or 2 years and got DBS done. So I'll advise you, do not go for stem cell therapy. It is not recommended. It is only a research tool, and it does not have any value in the current management of Parkinson's disease.
Just the last question, because with the pandemic that we've been going through, they want to know whether technology is going to play a role in helping patients and caregivers of people with Parkinson's and clinicians to manage Parkinson's better, and especially in India, if that's going to happen.
It is already happening actually. During the COVID lockdowns, the 2 major lockdowns, we reached out to the patients with telemedicine, and it is really a very good way of evaluating the patient. See, earlier days we used to give the patients a diary, to maintain a diary, maintain the videos and show to the doctor. Now, telemedicine definitely has a very important role. It is playing an important role in other parts of the world, in Canada, in Korea, in Philippines, Taiwan, etc. But now we have started. But what I advise you that it does not have, or at least it will not have a role in the initial evaluation of Parkinson's disease. So when you are first time seeing a doctor cannot do a telemedicine and start on treatment. So Parkinson's disease needs to be evaluated by a doctor who is a specialist, at least a neurologist. All investigations should be done to rule out, especially in young onset Parkinson's disease. We need to do MRI imaging to rule out sometimes a tumor, sometimes we have seen a cyst in the brain, etc. So first visit or first few visits should be done in physical, and later on the follow-up can be done on a telemedicine. It will have a role. There are certain technologies are now available, sensor based, that we can give you a sensor and you can wear the sensor, and later on the data can be analyzed offline or online, and we can evaluate and see how long you were in the off state, how long you were in the on state, what was the type of off state you had. So those advances we are gradually having in our country, and it will play a major role.
Thank you so much. I did say that was the last question, but
you can continue the questions. I don't have any problem.
Some caregivers have said, can you give them any advice for any caregivers who are here on our session today? Any advice for caregivers of people?
Caregivers. Yeah, I have already advised you actually in my third last slide. See, advice for caregiver and patient is almost the same, because if you are a lifetime caregiver for the patient, and the caregiver burden is really very high in our country. Okay. So I think you should take, first of all, if you have to take care of your patient or spouse or whoever you're taking care, you will get drained, and you have to take care of your health. And depression is one of the things, depression and anxiety, which is really almost equally affecting the patient, if not more, equally affecting the caregiver, if not more than the patient. Okay. So you should allow the patient, you should treat yourself. If you are depressed, you should take care of yourself and take antidepressants. One more thing is that I have seen many young professionals, young patients who have come with their spouses with a lot of intermarital problem and psychiatric issues, depression. See, you should understand that the patient or your patient is having a psychiatric problem, if the patient is having a psychiatric problem because of the disease. And the false belief, that is the delusions, false belief of the caregiver is not faithful to the patient is very common. Even I have seen a young patient who is having so much of visual hallucinations, so much of delusions, that he was suspecting his wife and was calling the police, searching for somebody in the house, under the beds. So these are totally chaotic. And I have seen patients who have, the whole family wanted to commit suicide because the patient was having severe hypersexuality, young patient was having severe hypersexuality, but there was nowhere they could confide to any doctor. They were planning. So all these patients we could help by tapering of the drugs, all the medications which are culprit. Okay. So all the psychiatric problems, the caregivers is always burdened by the psychiatric problems. See, motor problems is not much for the caregiver. Motor problems for the patient is not much for the caregiver. It is the psychiatric problems. One is depression. One is the caregiver is doing so much for the patient, but still he or she suspects the caregiver for poisoning or infertility, etc. So those things, if you see, you should consult a psychiatrist. Even not a psychiatrist, you can consult a neurologist. We will take care of the medicines. Maybe medicines are causing much more side effects than actually it is helping. So I have reduced medicines in so many patients. We have gone into 1/10 of the medicines what the patients are taking. They are very happy, and all the psychiatric problems, caregiver burden definitely comes down.
Okay, thank you. Sorry, I do have one more question, and this actually comes from one of your batchmates from Calcutta Medical College, Sanjoy from the UK.
Yes, Sanjay. Yeah, hi, Sanjay.
So he's very happy to see you. But his question is, in the emergency department, how does one stay vigilant about emergency manifestations of Parkinson's, and what emergency treatment is needed? So in the emergency department, how do they stay vigilant?
Okay, so I had actually hurried through those emergency presentations of patients of Parkinson's disease. So one is that a patient of Parkinson's disease can come with very severe off state, okay, rigid bradykinetic state, off state. In our country, we often sometimes find patients who have never been treated coming with that situation because they were never taken care in the house. So that is the first time PD. Second is that sometimes it may mimic or it may be one of the causes because of the neuroleptic use and etc. Okay, so this we should be very careful. Now, a patient already diagnosed as PD coming to the emergency, we should take consider the following things. One is that if the patient had a history of falls or some head injuries unnoticed, and they develop bilateral subdural, chronic subdural, comes with memory problem and then worsening. This is number one scenario. Second is the patients come with hallucinations, visual hallucinations, delirium. In this case, apart from the chronic subdural, you should look for metabolic abnormalities, very commonly hyponatremia in a country, sometimes the diabetic patients. infections, occult infections, chest infections, all these things, they can come to the casualty. So in this case, proper management in the casualty is important. Third thing, in the COVID situation, we have found anxiety attacks, panic attacks, stopping, the battery has got drained out and the DBS has gone off. They have come in the casualty situation. Fourth is, the earlier days we used to find what is known as neuroleptic malignant syndrome or stiff Parkinsonism hyperpyrexia syndromes. So they are the patients who again can be in a background of infection, metabolic abnormalities, or patients have skipped a lot of doses of levodopa or dopaminergic medications, or the patients may have been given a lot of neuroleptics, or a very close association sometimes can be with the serotonin syndromes. Okay, so these are the patients who come with delirious state, stiffness, hyperpyrexia. Then if you do the investigations, you may find increase in the cell count, infections parameters. Then CPK can be very high, that is CK, that is creatine kinase. If it is in thousands, we will suspect a NMS, and then the treatment strategy is different. If there are myoclonic jerks in this patient, then you may like to think about serotonin syndrome rather than a NMS. So these are the main things which actually the patient comes with in our setting, all these patients with Parkinson's disease. Yeah, Sanjay, you are muted. I can hear a voice. Tell me. I am seeing you after many years. Yeah.
Thank you so much. Thank you so much. We had patients, caregivers, allied health therapists, doctors as well attending the program. As I said, we had more than 400 people and lots of questions. But thank you so much for answering so many of our questions. And
no problem. Yeah.
Dr. Pareto, would you?
Yeah, so thank you so much, Dr. Pramod. The presentation was excellent. I think we've been working with
I'm sorry, because this, always I have a problem of that bar on the top, and the new computer is creating a problem. It doesn't go forward, some of the slides. I don't know what is
but the text was excellent and your explanation was even better. I think we've been working for so many years with Parkinson's, but today we learned so much more. And I really appreciate the presentation and the detailed question answer session. We always have a whole lot of questions that come up, and Nicole's and my back-end team have been sifting through them to see that we get the most crucial ones. But I'm sure we're going to call on you again, because I think we always have new people with Parkinson's joining. I think in the pandemic itself, we have at least 1,000 new people who have joined the society, and people are always looking for answers. Even we are looking for answers. And I think the way you explained the pros and cons of everything answered a lot of questions through your presentation itself. So I'm extremely thankful to you and for your time. And we look forward to a continued collaboration with you. Thank you so much.
Thank you. Bye.
Thank you very much. And thank you everyone for joining. If you would like to watch this webinar again, it will be on our YouTube page. The details have been given in the chat box, and we'll also share it here. So you can watch it on our YouTube channel. And we also have a lot of other videos in different languages. Hindi mein bhi videos hai Parkinson's ke baare mein. We have exercise videos. We have in different regional languages as well. So please do have a look at our YouTube page. And if you do know anyone who has Parkinson's and would like to join our program, please do give them our contact details. They can call us, they can email us. We have a Facebook page on Instagram. Please do let them know. Thank you once again, everyone, for joining us. Do have a good evening and weekend. Thank you.
Thank you.
Thank you. Thank you, Nicole.
Take leave. Yeah.
Yes. Thank you so much.
Thank you. Somebody has written that we didn't take some of the questions. You can send. We can send to her or him.
Okay.
Some questions were not answered. Yeah.
Yes.
Okay.
Yes. Sure. We'll do that. Thanks for that, Pramod.
Yes, apologies for the questions, but as I said, we had 400 people who have registered, and so we had too many questions, so we had to just take the most commonly asked questions.
Or we can do one, say, only question answer session. No need for presentation.
Definitely.
I think that is much better than, because the presentations always we feel that whether I'm reaching out in a technical terms, because it is very difficult to talk totally without, technical terms.
Right.
And for patients and caregivers, I usually do not want to use. But I understand there are a lot of other allied health professionals out there.
Right.
Who
We have
technique.
quite a number of allied health professionals.
Yeah.
So I think for that,
But I'll be happy to take only a question answer session.
that would be excellent.
Rather than
I'm going to hold you to that, Dr. Pal. Yeah.
Okay.
Thank you so
Okay.
much.
Thank you.
Okay.
Thank you.
Yeah. Thanks everyone for being there. If you have
Thank you,
Parkinson's,
everyone. Yeah.
and if you have someone with, with Parkinson's, remember we are with you to walk with you through this journey. So get in touch with us. My team's just waiting to reach out to you and work with you. Thank you. Good night and have a nice weekend.
Thank you.
I'll take leave. Yeah.
Yes, thank you.
Thank you.
Thank you.